He should be here soon. He usually is here.
They should be here. And nobody from the University of Miami, except you. You have to be a panelist. So you're ready.
Oh, me? Oh my God.
Yes.
Okay.
Sometimes the noon presentation may be a little tricky with getting.
People are eating lunch and they're still in the OR eating lunch, whatever.
Yes, or
They used to. Yeah. When did you you came to Miami to do your fellowship, right, Dr. Alex?
yes.
And when did you do your resident? 2000.
13 to 15.
13. Okay.
Yeah.
Right. So 2013, when you first started, this conference had all the residents and the fellows at the University of Miami. It was a big conference, remember?
Yeah. Yeah, and it was on a Friday. Usually it was a Friday.
No, what that's right. It was on a Friday. You're right. Friday after Friday. I guess the same times. Yeah, you're right. It was on a Friday. I've forgotten that. Where did you do your residency?
In Philadelphia, Lankenau Medical Center.
Which one?
Lankenau Medical Center.
The Lankenau. I don't know.
Lankenau.
Yeah. Oh, Lankenau. Okay. Is it affiliated with what, Albert Einstein or one of the
No, with
universities?
Jefferson. Affiliated with Jefferson.
Jefferson. Okay. All right. Okay. Now you're there. Very good.
Yeah.
Okay, I think it's 12:05. I think we can go ahead and start. And then I think if people join, we can include them.
Hello, everyone. I'll start
Let me introduce you both.
Go for it.
Okay, so yeah. So good afternoon, everybody. Welcome to the today's session of the Tele Trauma Grand Rounds. And today I have the pleasure of introducing both the speakers, Dr. Prashanth Palvannan, who's the chief resident, and Dr. Alex Nedlcoviciu, who is the clinical assistant professor from Thomas Jefferson University in Philadelphia. And today they're presenting a case titled Minor Trauma Causing Extremity Necrotizing Soft Tissue Infections. And it's a case series. So wishing you the best of luck, and over to Dr. Palvannan to start the presentation.
Great, thanks, Maya. As you mentioned, today we're going to talk about two cases that we felt kind of highlight the different unique spectrums of necrotizing soft tissue infections and have a unique perspective or a unique outcome that we thought would be helpful for everyone to hear and at least keep in the back of their minds the next time anyone comes across these in the trauma bay or in the ED. Great. So our first case starts with a 70-year-old male who presents with a left lower extremity open wound that's classified as a minor trauma that he incurred about a week ago. He says that over the last 3 days, he's had erythema, particularly the mid to distal left lower extremity. And it all started with this initial cut that you can see here. Just for orientation purposes, his knee is over here. This is his lateral aspect, and this is the posterior aspect. That's the anterior aspect there. He initially developed some fatigue. He presented to the ED in the morning and was seen in the morning by the emergency physicians and admitted to the medical service for cellulitis. Later that evening, several hours after his admission, there was a surgical consult placed and he was seen by the on-call surgical team. And at that time, as you would expect, there was a nice warm blanket covering the leg, hiding the ugliness out of sight from everyone. Very briefly, before we move on to this poor individual's presentation, I thought it was an interesting paper to present here from the Surgical Infection Society back in 2020, where it looks at patients who present with NSTIs and the importance of early, not only detection of an NSTI, but also the importance of having a surgical team involved early on in their care. In this study of 91 patients, you can tell that about 20 who were admitted to non-ACS services had poorer outcomes than those who were admitted to ACS services early on. In particular, the median time to incision in patients not admitted to a surgical service right off the bat led to a longer time of incision, which again correlates to having a worsening outcome, as in this particular case, delayed surgery or delayed treatment often can lead to increased deaths. So looking further at our patient at our physical exam, again, this can orient a little bit better, as you can see that that initial cut is out on the lateral aspect of that left lower extremity. There's clearly further demarcation of what appears to be necrotic soft tissue, as well as some bullae that have formed on the anterior surface. And again, this patient had tenderness sort of all above the knee into the proximal or distal portion of that left thigh as well. So just again, in words, there's tenderness that goes up to the upper thigh as demarcated here by the horizontal line at the mid thigh. He's insensate all throughout this black eschar in the left lower extremity. But in particular, and what was a little strange about this presentation, is that the most tender region was actually along this dotted line on the lateral aspect of that mid thigh in this area, well away from where you would expect him to potentially have a significant amount of tenderness with the skin changes. And also of note, there was gray dishwater fluid that was basically weeping from any open wounds or open blisters that he had on both the lateral and posterior aspect of that leg. Very quickly, the decision was made after seeing this lower extremity that the patient needed further debridement, and he was taken to the operating room, where he underwent a wide excisional debridement focused on removing any devitalized tissues, any necrotic tissue. And in doing so, he also underwent effectively a 4-compartment fasciotomy of that left lower calf, as it was felt that his overall leg was a little tight. And after removal of that layer of skin and debriding some muscle, we felt that this would be important for the patient to at least release some of the compartments and attempt to reach healthy appearing tissue. Interestingly enough, at least in my experience, it seems like a little off course, in that as after the surgery was done, he was actually still in the ICU, intubated and on multiple pressors. Usually patients, if you've accepted that you've gotten all the infected, devitalized tissue, typically do well and typically start coming off of pressors with further resuscitation. Unfortunately, this patient didn't. And as such, he was scheduled for a second look the following day. As you can see, this is his, this was the incision that was, or the debridement that was done. You can see that the outer skin is now completely removed, up to down to the ankle and up to the distal thigh with the knee overlying it. This slide is effectively to show what happened in this case while we were doing our fasciotomy and doing our compartment releases. We recognize that if you go too lateral with that initial incision, as a teaching point, and you often go too low, the intramuscular septum between the anterior and the lateral compartment often can be confused for the septum between the lateral and the superficial posterior compartment, which is what happened initially. And if that isn't recognized and you just release that one layer, you effectively no longer get a 4-compartment release, misreleasing your anterior compartment. Thankfully, we recognized this in the operating room, and we were able to veer more anteriorly from our initial lower incision and release the anterior compartment as well. Again, this is just showing further more photos from the operating room in that initial take back to the OR. And what you can note interestingly is here by the ankle, there still appears to be some dusky skin with concerns for maybe further infection. And again, this is now showing you the medial incision to release that superficial posterior and the deep posterior compartment. This is his dressing in the next 24 hours during that second look. And you can tell on that lateral aspect again here, that duskiness around the ankle is certainly worse than it was on the prior pictures. And now you can also see some more devitalized tissue, or at least the beginnings of what appears to be mottled necrotic tissue up at the thigh. with concerns that there might be more ascending infection that hasn't been addressed initially. And again, this is what the rest of the tissue now looks like on that take back the second time of the operating room. So with that in mind, we, after the second turn to the operating room, the patient still being on some vasopressor medication to keep his blood pressure up, still requiring to be intubated and otherwise not out of the woods, we did gather some additional information talking to the patient's daughter with regards to the actual trauma that occurred. And it sounds like at that time, he was docking his boat in the Chesapeake Bay when he initially incurred that that wound on the lateral aspect of that left leg. Now, with that in mind, and seeing kind of his presentation and his stories, his story and the pictures, does anyone have any idea of what the causing agents could be? And are there any particular considerations for his critical care based off of those thoughts?
Thank you, Dr. Palvannan. Dr. Armstrong, would you like to share your comments first?
Yeah, so initially, how did he wind up on the medical service? I would think, the triage nurse would have seen that. In my day, there were no ER doctors. There was medicine or surgery, would have gone right to actually minor surgery, to the surgical intern. With ER docs, they would have made the decision. But so that's an important point. That's a big error that needs to be prevented from occurring. And in this case, so did he? I guess he had no crepitance on exam. No crepitance. No.
No.
Okay. And what do the cultures show, and what antibiotics did you have him on?
So my understanding is he was on broad spectrum antibiotics at this point. Just he was on vancomycin and clindamycin. I'm not sure, Dr. Nedlcoviciu, would you know what his culture showed at that time?
So his cultures were pending, and he was like the next day when we took him, there wasn't anything back. There was some gram positives, if I recall it, but there was no crepitus, and all that area that was black, it was insensate. He did not feel pain at all. Actually, the pain was more like up and excruciating into the areas of like erythema where we had that dotted line drawn. As far as how he ended up on the medicine service, I don't know, but sometimes they end up like that. And then you get this minor trauma consult, can you check this leg? And it's always scary, especially when they're in the MICU.
Yeah, and why he was admitted, if it's minor trauma, why admitted to the hospital? But I think that's the issue to resolve, because it's an error that increased the morbidity of the patient. But anyway, and it's not surprising about the insensitivity, because that the synergistic fasciitis destroys the blood supply to the overlying skin, and there's necrosis of the skin. So I would be concerned, first of all, whether or not the blood cultures are positive, whether the knee joint could have been invaded, but also a possibility of other marine organisms, so parasites or amoebae or whatever. But in general, that the picture sounds like synergistic fasciitis or necrotizing fasciitis is what he has, and we didn't see what the fascia looked like before you debrided, but it was a typical case of that. And it looks like he's on more than enough antibiotics. It's a little bit of overkill, but Zosyn or ertapenem by itself would be okay. I think clindamycin, if you want to have double for anaerobes and aerobes, but I would look for another source of seeding, if he's still toxic and febrile, and does he, I don't know how old did you say he was, this man?
70.
Oh, 70. Yeah, could he have valvular disease and seat of the heart, and in which case the blood culture would be positive. So that would be my concern for the continued sepsis. Thank you.
Thank you, Dr. Armstrong. Dr. Hodgman, do you have any comments to make?
No. This was obviously, now we are learning it was with salt water, that it was not very clean. So seeing that we worry about strep, particularly there is no gas in the tissue, A streptococcal infection, usually a synergistic one with this is beta hemolytic strep with something else. And more rare will be an infection by Vibrio, but that's kind of very, very rare. But I don't know, that's all I have to add in terms. And we see quite a few cellulitis that they get admitted to medicine for IV antibiotics. They never develop into necrotizing soft tissue infection. If they have a soft tissue infection when they come in, yes, it's clearly that's the case. But if they don't and they develop later is when they become a problem. But I don't think it's realistic to admit these patients to the surgical service all the time with cellulitis that 99% of them will not require any treatment. So that's it. And occasionally it could be a mycosis, but this doesn't look like mucor or anything like that. The way that it necrose, it looked more like a bacterial, synergistic bacterial infection, like Dr. Untrak mentioned. And I would blame probably Streptococcus, maybe a coliform associated with it.
Thank you, Dr. Hodgman. Yeah, actually, because you mentioned docking his boat, I was thinking maybe Vibrio could be a possibility because I'm studying for my step 3, and I had a case recently where it was a shellfish injury, and he had malignant necrotizing fasciitis after. So that's where my mind immediately went to. But I'm going to give it back to Dr. Palvannan to continue.
Great. Yeah. So at this time, like Dr. Untrak and Dr. Hodgman had mentioned, our big concerns were any synergistic infections. Were we missing anything else? We're waiting on our cultures and seeing how septic is this patient. Does he have any positive blood cultures and whatnot? So, like you mentioned, this patient had what was identified as Vibrio, leading to malignant necrotizing soft tissue infection. So just briefly, because I am very far removed from step 3 and did not remember much about Vibrio. Vibrio vulnificus is a free-living bacterium. It's found often in our waters and our marine environments. There's 3 different types. Most importantly, the most common type for human infections is B1. It often peaks within the summer and late fall. It importantly is one of the leading causes, as Dr. Kumar mentioned, leading cause of shellfish-associated deaths in the US. And important to our gentleman here, 8% of bacteria within the Chesapeake Bay waters is comprised of Vibrio vulnificus. Also, there's a higher risk of developing these malignant NSTI infections in patients that have other underlying chronic comorbidities such as diabetes, liver disease, or hematochromatosis. And you can often see it in older individuals and older men. As a point of sort of trivia, I guess, oysters, which are a delicacy, often tend to be a feeding concentration of Vibrio, so be careful with your oysters. And finally, in terms of clinical features, in particular, I know we talked about wound infections, but particularly those that develop Vibrio-related necrotizing soft tissue infections have a primary septicemia that about a third can lead to shock EIC and with a very high mortality rate just on initial presentation. And again, in terms of coverage for patients that you suspect have Vibrio or could have underlying Vibrio, you want to make sure that you include doxycycline in their antibiotic regimen. Again, this is just another paper discussing just overall the abundance and distribution of Vibrio. Here they looked at Vibrio within the freshwaters of the Mississippi Sound, and they noticed that often with increased salinity of the water, meaning water that's freshwater will typically have higher rates of Vibrio, whereas salt water often does not. Like I mentioned, our individual was in the Chesapeake Bay, so you would expect that he'd be okay, but again, as a rare presentation, he could have that occurring. So how do you go ahead and treat this? The key here is to have aggressive early surgical debridement. Also, in terms of controlling their sepsis and in terms of putting antibiotics on, we typically prefer 3rd generation cephalosporins along with, as I mentioned, doxycycline or fluoroquinolones, as well as minocycline. There is there are more aggressive regimens. One is listed here. There's other aggressive regimens listed in the case reports, but as an early starter, doing a 3rd generation plus doxy is often going to be your best bet for having good medical antibiosis on top of your surgical debris. When looking at really what are the prognostic factors and how does that affect our treatment mechanism, this is a study in the Archives of Internal Medicine back in 2006. It looks at various antibiotic regimens, and as I'd mentioned in the slide before, what they identified here was utilizing a 3rd generation cephalosporin along with tetracycline. We've now also accepted doxy as a better alternative, but they felt doing those two showed a reduction in the mortality rate in the patients that they had. They basically were a retrospective study that looked at 5 various medical centers within Taiwan. They divided patients into 2 groups, and one group received that 3rd generation plus tetracycline. The other group received either a 1st or 2nd generation along with an aminoglycoside. And they, again, were able to identify that the 3rd generation plus tetracycline was overall a better antibiotic regimen, led to decreased mortality. Finally, this is just another paper in brief. Here they looked at the utilization of fluoroquinolones and 3rd generations along with, here they did minocycline as the antibiotic regimens, and they identified that as being one of the best regimens possible. The key from all of these papers, not to get into the minutia, is recognizing early that this is potentially a cause for the necrotizing soft tissue infection you're dealing with, and going ahead and making sure to add on either doxy or minocycline as your regimens on top of whatever other antibiotic therapy you have. As mentioned earlier, we were on vancomycin, zosyn, and clindamycin. Again, that was, while very aggressive, still did not cover the specific strain of Vibrio vulnificus that we had, and we should have had this patient earlier on doxycycline. Now, finally, this is a paper looking at patients who had infection with Vibrio and seeing how the rates of death increased with certain types of prognostic indicators, such as underlying chronic medical comorbidities, as well as their initial presentation. The key things here that we wanted to really point out as a takeaway message is that patients who have underlying hepatic dysfunction and a history of diabetes on presentation have often a worse outcome than those that have either just diabetes alone or hepatic dysfunction alone. The reason this is important is that in your post-operative critical care setting, once you've undergone your initial surgical debridement, it's important to recognize with the current medical comorbidities that patient presents with and how they're responding to your initial therapy. You want to make sure that you're recognizing patients early on that need more aggressive debridement, that might need more aggressive antibiosis based on their level of hepatic dysfunction and underlying physiology. That was everything that I had for the first case. Dr. Nedlcoviciu, do you have any other comments on top of that?
No, I think, yeah, it was weird that he wasn't, he was still on a couple of pressors, and his blood cultures grew Vibrio the next day when kind of everything surfaced out and with the information from the daughter. And as soon as we put him on doxy, he kind of started turning the corner. So it's rare, but it's not rare when it happens to you when you're on call. So I always say.
Thank you. I think Dr. Rodriguez has a comment. Yes, Dr. Rodriguez. Dr. Rodriguez, you're on mute. Dr. Rodriguez, you've muted yourself. Yes.
I'm putting a sleepy at the doctor in blue there. You know, when I'm sorry, I said I arrived half of the presentation. I was waiting for the whole day, and when you get 80 years old, you forget about things. Anyway, I was lucky in 1976 to be a fellow in shock trauma in Baltimore. We have 3 hyperbaric chambers where you can put 10 people inside. So we're the center of the world, hyperbaric medicine, precisely for toxic CO2, for fires, and necrotizing fasciitis. So we saw hundreds of necrotizing fasciitis. We didn't worry about the vibrio. I know you sound like a CSAP, vibrio. Yeah. The more important thing, the point for the resident, I don't know if any resident here listen this, okay? But the most important thing is something you said, but need to be reemphasized. The management of this patient, the number one thing is extensive debridement. If you don't do extensive early debridement, the patient's dead. No matter what, vibrio, no vibrio, whatever, is dead. Okay, so when I saw Roy Myers, who was the guy who published most of the papers those days, now everything in Chinese, I see that. I was reviewing that, this guy, when they operate patient with necrotizing fasciitis, take half of the body out. I said, it's crazy, but that's the only way the patient survived. As a matter of fact, the idea was, I don't know if it's true or not, as a fellow, I had to dive with the necrotizing fasciitis patient and do surgery at the same time. I was in the hyperbaric chamber, debriding the patient then, at the same time where the patient was under pressure. That's the theory that Cowley has, that the priority was oxygenation, but no oxygenation. The hyperbaric medicine is supposed to block the neurotoxic effect of this necrotizing fasciitis. I don't know if that has been continued proving or not. Shock trauma still have 3 or 4 chambers, making a lot of money, with this patient coming to the whole world to do this. But I don't know. It's all Chinese here in vibrio. But remember, the most important thing in treatment of necrotizing fasciitis was, and it is, early debridement, extensive debridement. No, it's not just taking the thing looks like it could be. No, everything is dead. So you had to remove everything and the patient survived. That's my contribution.
Thank you, Dr. Rodriguez. Dr. Antrek, would you like to make any final comments before we move to the next?
Yeah, so I guess about the first issue I raised about how the patient arrived on the surgical service, it depends on how the leg looked when he presented. It may have just had a little cut, and then progressed very quickly during the day. So that's the issue. And I guess the point is when patients come in, it just needs documentation, and that'd be reasonable. The other thing is, I guess you could have given the patient also a fluoroquinolone, so Levaquin or Cipro IV. That, from what I read there on the slide, that's there you go. So that's fine. And I guess he wound up doing well. He got skin grafted, or is it too soon?
He ended up, he survived just because of he had the different family members. Like he had somebody in Maryland, he had somebody in Pennsylvania, somebody in Delaware. He ended up going to Maryland for skin grafting and whatnot because of family situation for him. Yeah. But when he left, he was like off pressors, extubated, just getting dressing changes with sedation in the ICU.
And how long after adding the doxycycline did he effervesce? Did he turn the corner? 1 day, or the first dose, or
more? A day and a half.
Yeah. And the other thing is, I would have guessed that Chesapeake Bay would be either salt water or heavily brackish, but because it's open to the Atlantic Ocean, but it's really fresh water.
I guess, but the thing is, like, he didn't tell anybody. I guess he kind of got a little like septic, and he just was kind of responded, and he didn't tell anybody what he did, not even his wife, because the wife was like, I don't know what he did.
I'm just talking about geography. Who knew that it was the Chesapeake Bay is fresh water? I never knew that, but anyway, so
I didn't know that until I looked up some papers and I saw 8% is in Chesapeake Bay, and then I made the connection with where he parked his boat. So
you are in Miami.
Okay.
Yeah.
Thank you, Dr. Antrek.
And by the way, Dr. Rodriguez, I'm going to be 80.
I don't know what you say. I cannot hear you.
I'm going to be 80. You said you're 80. I'm going to be 80.
Yeah, you look 79 like me. Yeah. Yes, this is good.
Yeah, right.
That's good. Yeah.
Someday,
You know,
someday, God willing.
you know, one of the things I disappointed about myself is I trained in well, I was in a place like shock trauma, the Intergalactic Center of Trauma of the Universe, and there were only 2 trauma centers, you know, Ryder and shock trauma those days, the famous, I guess. I don't know the word for some reason or not. But the disadvantage of that is I have everything is super specialist there, don't belong to university, any place, belong to shock trauma. I have a infectologist who work only in trauma, you know, Dr. Kaplan. And I can call anytime or he can come and tell me what to put the patient on. And that I envy you, doctor, because you tie the doxyclean and this. We didn't mention vancomycin. Some studies show about vancomycin also. And I have this disadvantage or have somebody there. I never learned really about antibiotics because I have to ask, hey, what do I give to this patient? I said, well, you give it this, and this. He has experience. I didn't. So you're lucky, doctor, that you have to think. I didn't have to think. That's the disadvantage to being a super place where you don't have to think very much. I don't know how it's Rider now. You have Rider 1, Rider 2, Rider 3. You keep making franchises of Rider. Go ahead.
Thank you, Dr. Rodriguez. Dr. Hodgman, do you have any comments before we move on to the next case? Dr. Hodgman, you need to unmute yourself.
Sorry, can you hear me now?
Yes, we can.
Okay, so no, it's just that Vibrio survives very well in salt water. I remember in the 90s, there was a big epidemic of cholera in Peru, and it was from the waters of the sea, kind of like the seafood was contaminated. So, and oysters kind of like, as you mentioned, filter Vibrio, and that's what happens. So that's all.
By the way, I am from Peru. Yeah, thank you. I remember the cholera. I don't know, I was there. What year was that, doctor? What year you mentioned that?
I know it was in the mid 90s or
Yeah, it must
90s.
be because I left in 70.
And it's kind of funny because the only cases that happened in the United States from that epidemic were brought here by an Argentinian plane. I am from Argentina. The plane did a leg in Lima, and they boarded sushi, which was not common in Argentina at that time to have sushi, and they served sushi.
Oh, yes,
and the people on the plane got sick. Yeah,
You don't know
and an attending surgeon who trained me was in that plane. That's the reason I know that happened. Was one of the first, was the only cases at that time of that epidemic that reached United States. So one of the cases was an Argentinian surgeon who trained me. So we just bring only bad things here, I guess.
Produced by a Peruvian Vibrio. That's very interesting, doctor. Typical Argentina.
That was Vibrio cholera at that time, I remember.
I know. Very good.
Okay, thank you, Dr. Hodgman. Thank you, Dr. Rodriguez. Back to you, Dr. Palvannan, to continue.
Great. So we'll move on to our second case. Our second case is a 56-year-old male who also presents with a left lower extremity wound with some surrounding erythema. He comes in saying he's had 3 days of erythema around this wound, which, as you can see, is right here in the mid shin, where he has an open wound that's actively draining, and he states that it occurred after some minor trauma. Again, he has a history of hypertension, diabetes, hyperlipidemia. He's had a prior right hip replacement on the other side of the leg, and his meds and allergies are listed. He has no prior history of smoking, drinking, or drug abuse, and he lives with his family. And as you can see in the second photo here, he has some extensive disease as well on what appears to be the underside of that left eye. Here, his labs are very concerning. He has a leukocytosis. He is hyponatremic on his BMP, and his Larinac score certainly, if you believe in it, would be elevated. He has an initial ultrasound of that leg that's done by the ED that shows no DVTs. He has an X-ray of that leg that shows no osteomyelitis, no foreign body, no tracking of air across the soft tissue. Again, this is that X-ray, and as you can tell of that left leg, there's no foreign materials. It's a little grainy, but truly there's no air tracking in the subfascial planes on any of these X-rays. He does undergo a CT of his pelvis. Again, as you can tell here, this is his right hip replacement that he has. And on a CT scan, you basically see that there's no subcutaneous emphysema, and he has not really any terribly large collections of fluid or anything. So there was a discussion that was made here, or there's discussion that was had on whether or not this patient needed really just an incision and drainage versus a wide debridement, or potentially amping the whole leg. And we felt that that amputation would, at least for now, be a little aggressive. So we figured we'd start with an initial IND, see what we could identify, and if there were other locations that appeared to be involved, and decide based off of that how wide our initial debridement should be. So this is after our initial incision and drainage in the operating room. You can tell that having opened up that initial incision, initial wound on the anterior shin of that left lower extremity down, there's now on the dressing change multiple areas of devitalized tissue. The wound itself doesn't look healthy. This is just another angle. As you can see, it's kind of a medial, anterior medial incision that's occurred there. And posteriorly, this is what it looks like on the back of the leg after some debridement. And here you can see there's still some ratty skin edges that certainly appear to be involved. This foot overall does not appear to be doing all that well. So the discussion again was had in terms of whether there needed to be further wide local debridement versus yet again just an amputation if this foot otherwise was not salvageable. So the patient underwent additional debridement, and over the course of the next several days, he was in the surgical ICU. He was eventually extubated. He continued to have ascending infection, he continued to have further soft tissue involvement. And without getting into all the details, there eventually came a time when we recognized that he just had too many extensive debridements. There's clearly uncontrolled infection in that leg, and that the patient would need an amputation. So what would you all do at this time? Would you continue with operative debridement? Would you say, let's just do dressing changes and do just antibiotics? And if you were going to continue down the route that we thought in terms of amputation, what level would you consider? And recognizing this patient is ambulatory, so he doesn't necessarily go right into an AKA because he's contractured or immobile.
Thank you, Dr. Palvannan. Dr. Rodriguez, do you want to make your comments?
Well, I think we have to use here evaluation. Whatever you did is correct in the beginning. You know, you did more extensive debridement. I think that's what you had to do it. Despite your extensive debridement, looks like the patient still need more debridement. So you keep doing more debridement. The antibiotics, I'm sure that you want to talk antibiotics. I don't know much about antibiotics, but I assume patient was in the right antibiotics. But there's coming the point here that you have to make a decision, you know. Is this going to be a functional leg? You keep the debridement and taking all the muscles, and just going to have a piece of bone there, then it's useless to have there. There are indications. I know the indication to do amputation in the patient with trauma and vascular trauma, but this is not, you're not classifying grade 1, 2, 3, C, whatever. This is infection. It's different indication for amputation. But by common sense, I think this patient, more likely, I would say it ended with an amputation, be the most common, because otherwise, this is not going to get better. And this patient is going to be, remember you and your whole family when he needs a lot of pain medication. And something nobody has talked yet, I would like somebody to make commentaries about the use of hyperbaric medicine still is viable, you know. And number two, you know, the fact that many of these patients that go home returning, you know, coming back, all right? Something you have mentioned that.
Thank you, Dr. Rodriguez. Dr. Hodgman, would you like to make some comments?
Sure. You know, I'm always very conservative with amputation, and maybe to a fault. I without seeing the patient, it's difficult to say for sure. In one of the pictures appears that the saphenous vein is exposed. So you will have to ligate that and or resect that because eventually it will desiccate and bleed. The patient seems to have an unhealthy skin in the area. So I really don't know if he has a peripheral vascular disease making the situation worse, but the skin appears to be very thin and the tissues underneath, at least the impression in the pictures is fibrotic. So you had, it's possible to skin graft there. Yes, it is, but eventually becomes a time that is very difficult. Having said that, many patients refuse amputation. Many patients say, oh, I'll do everything to save my leg. So can you do dressing changes for a long time? Yes, you can if the tibia is not exposed. So if you had to do an amputation, considering the extension of this, I doubt that you can do a below knee amputation, which would be the ideal one because there is no tissue to cover. So they're all bad options, unfortunately. You don't have a good option here. Regarding the using the hyperbaric chamber that Dr. Rodriguez was asking, it only works if the organism is a anaerobe, a mandatory anaerobe. If it's a facultative anaerobe, probably will not do anything, which there is no gas producing organism here. So makes me think that probably it's not. So many places don't have, we have here some hyperbaric chamber, but only the patient can go in. It's not the big hyperbaric chamber that you have in places like shock trauma or other centers where you can do this. The only thing I know about hyperbaric medicine is because I do scuba diving too, and always been interested in the topic, not for treatment of these infections. So it can be tried. I don't think it would not hurt, it might help. But I think that if the question is being asked here, it's probably because the patient went to an amputation, it probably will be an above knee amputation. Thank you.
Thank you, Dr. Hodgman. Dr. Anchak?
Yeah, so my concern here is a patient in his, I forget the age, in his 70s, late middle age, is that right? With diabetes, hypertension, hyperlipidemia,
Like 56
and those, oh, in his 50s, okay, but still diabetes, hypertension, hyperlipidemia, and no wounds in the foot, no gangrene in the foot. I would determine the vascular status of the leg. You know, start with non-invasive arterial vascular labs, and what I would be concerned about is could he have a simple correctable lesion like a simple SFA occlusion that can be treated with angioplasty or a stent, and that's the cause of the spreading infection, that poor vascularity of the leg. So I would want to rule that out. So I didn't catch it if you mentioned the vascular, the pulse status of the feet, but I would be concerned about that. If that wasn't the problem, or if he had non-reconstructible vascular disease, then I would agree that if he didn't improve with optimal antibiotics based on the culture results, wide debridement, and if he continues to be septic and the infection's ascending, then he would need a life-saving amputation at 56. I think he would probably take it, but I would be concerned about. I would get a vascular consult, see if they can maybe do a digital angiogram of the common femoral or iliac common femoral all the way down to see if there's something you can just fix with a balloon.
Yeah, there wasn't anything fixable. I mean, he did have diabetes and had some microvascular disease, but nothing to intervene. He had the ABI, PVR on both legs, but there wasn't anything that vascular said they could intervene.
What were the ABI? What was the ABI?
I don't remember the top of my head, but vascular said there's nothing that would require any intervention. He did have some microvascular disease because of the diabetes, yes, but nothing waveform wise to see anything significant between both legs to require anything endovascular.
Oh, so in other words, the perfusion was adequate. So it's either the perfusion was adequate or it's bad, but there's nothing, but it's not not fixable. You know, those would be the two choices. But it sounds like it was not a vascular issue. Yeah, in which case, then I agree with what you said, that you may need to, you know, just be sure he's on the right antibiotics. He's debrided, and he may need an amputation.
Thank you, Dr. Anjak. Back to you, Dr. Palvannan, to continue.
So as most of you already mentioned, we did end up going through doing an amputation. We did a left above knee amputation, as mentioned. Unfortunately, post-operatively, the patient didn't do the best. On post-op day 3, he had a low-grade temperature. He continued to have a leukocytosis, and we started noticing that there was purulent drainage from the left AKA incision, with concerns regarding further underlying infection at that stump site. The patient was started on antibiotics, and infectious disease consultation was done as well. Wound cultures were taken from that draining wound in a couple locations where the stump was opened up, and those cultures ended up growing, interestingly, Salmonella as well as Candida glabrata. This is just a representative image of a CT scan of that left AKA stump site. As you can tell, again, there's no collections that are identified there. He, on exam, still continued to have purulent drainage. And as I mentioned, we did open up a certain a couple spots on this stump to try and release any underlying fluid. Particularly on exam, he was very tender, and thus the decision was made to do this in the operating room, and the patient underwent an exploration washout of that left stump and had some debridement of the underlying subcutaneous and soft tissue infection. Following this and following closure of that AKA stump over subsequent washouts and back placements, he then began to develop this lesion that you can see in the picture on the superior aspect of that left upper thigh, just above where the dressings for the AKA stump sort of ended. With concerns that maybe there was further ascending infection that we were missing, the patient underwent yet another CT scan following other subsequent washouts over the course of his prolonged hospital stay. And at that time, he underwent debridement of that lesion as well. Again, the scans show that there's no collections, there was no signs of rising crepitus or subcutaneous emphysema. And following debridement of this wound, this is sort of what we were left with, and ended up doing dressing changes locally for, or vacs rather, locally for both this as well as the stump. And as you can tell, that's kind of where our vac setup was. So very briefly, just time permitting, what kind of diagnoses sort of pop up into your head? What type of infection could this be? Or not an infection?
Thank you, Dr. Palvannan. Dr. Anjak, what do you want to make your comment?
Yeah, that's it looks like a target lesion, that bullseye lesion with necrosis, and that's pathognomonic of something I'm forgetting. It's a form of skin necrosis. What now?
I said it has a spider hanging from the floor and rider. No, I'm just joking. You say you're trying to figure out. Sorry.
Yeah, it's that central area, central necrosis. It looks like a necrotic area in the center that was probably insensate. But anyway, I mean, if the wound vac worked and the wound started to heal, I guess it's moot.
May I ask a question? If there is a role in what do you think about the role of MRI in this diagnosis of this? Because some people think, and I use a couple of times, I'm not sure, they can tell you if it's necrosis or no, it's not necrosis. So it's because it's very deep, it's better than CT to make diagnosis specifically. The radiologist can tell you. They can say if this is the necrosis fasciitis or it's not. What do you think about that? And second, in Ryder, do you have hyperbaric chamber? You probably have it, right? You're in Riders, right? No? You're from Ryder? No, the doctor.
No. We're from Thomas Jefferson.
Oh, I'm sorry. I thought you were. No, it's okay. I was going to kick on you. I said Ryder must have a hyper. They're always trying to have what we have in shock trauma. Okay, go ahead. How about the other thing?
So we do not have hyperbaric chambers as far as I'm aware. In terms of MRI, that's actually a good point. I think it's something that to consider. We often don't, as you all know. I think a CT can give us the same soft tissue findings and is often faster. And typically, we're just looking for subfascial emphysema collections, et cetera. But I guess in this case, where we're scanning the gentleman multiple times and we're a little lost, the MRI might be more helpful. I don't know if Dr. Nedlcoviciu has any other thoughts there.
So when we got involved with him, he already had the amputation. The MRI, no, we did not think about getting an MRI. I do remember his kidney function was not the greatest between everything that was going on with him. So, but yeah, we can consider
interesting
that in
thought.
the future. Yeah.
Thank you. Dr. Hodgman, do you have any comments to make?
I would probably call dermatology. Many of the skin lesions that we tend to think that they were insect bites, it's usually staph or strepto. But honestly, I really don't know. I would just this is kind of like it looked like it was a bullet there, so I would think it's staph or strepto, but honestly, I don't know. I will wait for the cultures and talk to dermatology.
Thank you, Dr. Hodgman. Okay, I'm going to give it back to Dr. Palvannan to solve the mystery today.
So it's a little unfair. We did kind of leave some information out for everyone to kind of leave it as a mystery. He also, in the course, started developing a lesion on his hand and across other parts of his body.
Yeah.
The concern is this pyoderma that he had underlying, and the stress of the infection he had initially could have led for his pyoderma to blossom. And as such, as Dr. Hodgman mentioned, we did consult dermatology, and the patient underwent biopsy of that right hand. Now, these are his initial pathology reports. As you can tell, the first pathology report from the operating room of the AKA specimen showed acute and chronic inflammation with skin ulceration. And then again, from the right hand, you could tell that from the report on the 11th and again on the 17th, the patient had first granulomatous disease and then eventually had dense neutrophilic infiltrates with consistency for pyoderma. He was actually started on treatment with steroids following the biopsy on the 11th. And after the results on the 17th, it was confirmed that the patient had pyoderma. He was started on high-dose steroids, and our operative debridement stopped at that point. We recognized that there was likely no further underlying infection, and lo and behold, we recognized that very soon the left AKA stump started looking significantly better, and he just required Monday, Wednesday, Friday vac changes with initiation of the steroids. And again, this is what the lesion on his thigh looked like after starting steroids versus before. And you can tell that was probably our initial debridement there. And you can see this is starting to granulate again and is starting to heal. And with his arm, or his hand rather, this was what it looked like following steroids. I know we're kind of short on time, but very briefly, we looked at pyoderma and the misdiagnosis of pyoderma resulting in amputations. This is a study from 2009 that showed in 14 cases there was about a 10% rate of misdiagnosis, and most often, like we had in this case, the concern was for underlying necrotizing soft tissue infection. And the key here is early dermatology consult. Yet again, this is another paper that looks at multiple studies. And in this, the key here was that early dermatologic consult or early understanding of potential dermatologic underlying condition led to avoidance of amputation in about 4 patients. The overall conclusion is these are very challenging diagnoses and very challenging differentials. We always recognize underlying medical comorbidities that make people more prone to having infections such as pyoderma. And also, like I mentioned, don't ever feel bad about getting consultants involved, especially in weird cases and weird situations, rather than continuing to debride and going down a route requiring amputations of multiple limbs or more proximal amputations as needed. The last thing that I thought it was very interesting is that the literature shows while staph and enterobacter are often the colonizers for non-infected wounds from pyoderma, you can have other infections or other colonizing bacteria as well. In our case, we had salmonella as one of those offenders. And thank you. That's all we had for the 2 cases today.
Can I make a comment very quickly before everybody leave? I think one of the things I learned, many things I learned from shock trauma in my 25 years I was there. But one thing I learned is that sometimes to be trying to save limbs can be very dangerous. Yeah, you know, we have these mangled extremities there that we have plastic surgery came from Johns Hopkins. You know, they are the group who work with us. They put flaps and after flaps and after flaps, trying to save these mangled extremities, like we're trying to save this extremity. At the end, these patients hated this because they ended up being drug addicts, you know, with some medications. So you have to be very careful. This business of trying to save extremities sometimes it's better. So in reality, I asking you the last question: are you happy the fact that you guys cut the legs off the right time? Seems to me, because what do you think?
Yeah, I think the amputation was certainly needed. I think the initial infection was different from his pyoderma. I don't think we feel that the initial insult was pyoderma and that we cut his leg by mistake. I think that was true what he needed. I think without recognizing what was happening, this is a patient that I could see undergoing debridements of his hand, debridements of his upper thigh, and potentially getting higher amputations or further surgery that he didn't need.
Yeah, I mean, I think his leg was kind of, you know, when we picked him up, he just had amputation, but it just didn't look right. And Prashanth and I were thinking, well, what can this be with this lesion on the thigh? And you know, he healed and he's ambulating with the prosthesis. I mean, it's not the greatest thing, but we're happy that we figured it out and he did not lose his right hand and he's right-handed.
Thank you so much. Dr. Andrzej, do you have any final comments to make?
Yeah, so for a patient that was growing a yeast and the salmonella from the wound, had he been given systemic steroids and with underlying diabetes, I don't know, that might not have worked out too well. So and then the other point is that's, you know, I read about this about 6 years ago, that appearance, that necrotic central lesion is pathognomonic. I couldn't remember it, but it's pathognomonic of pyoderma gangrenosum. That's it. But you know, it's a long time reading about it. And your point about getting consultants is very good. You know, and you would have that you sent that tissue off, didn't you? When you debrided, you sent that to the lab, to the pathologist, and did he report back to you a couple of days later? It's pyoderma gangrenosum, or the dermatologist?
Only on the second. That one did not show up as anything, and the biopsy from the hand initially was not showing neutrophilic infiltrate, but it was rebiopsied, and he was on steroids started, and that showed dense neutrophilic infiltrate, which is suggestive of active pyoderma gangrenosum.
Right. Well, two very good cases with these unusual etiologies, and it's very good. Very good presentation.
It's rare until it happens to you when you're on call, and just kind of like watch out for the minor trauma extremity concept.
Yeah, and it's rare. Yeah, it's rare, but for this patient, it's 100%. There you go. So whatever, but it's you know, it was a good immunization here. Pyoderma gangrenosum. Right now, I'll remember it.
You should sell this picture for New England Journal of Medicine, you know, or
yeah.
That's
That's a good example of the images in clinical medicine. There you go.
Thank you, Dr. Andrzej. Dr. Hodgman, do you have any final comments?
First, I would like to give credit to whom the credit was due. Dr. Roberto Cortez, in the comment section, he mentioned pyoderma and suggested biopsy dermatology consult and pyoderma will improve with steroids. So one in this whole group at least was proven correct. So, and I think Dr. Cortez is out now, but he was until 2 seconds ago. Besides that, no, I don't have any more comments. This is kind of like what we do as acute care surgeons. We take care of these complex patients that frequently surprise us. And we always have to have an open mind. That's all. Thank you.
Thank you, Dr. Hodgman, and thank you, Dr. Palvannan and Dr. Nedlcoviciu, because there were very important take-home messages from both of today's cases, I think, for everybody here.